we're going to talk about peds today. My gut tells me that when we're talking about NCLEX and peds, I have a feeling that it's not going to be a bunch of peds diseases because they're so specific. And unless you're in the pediatric world, you're not going to be aware of them or competent in your knowledge base with them. I believe, if I wrote NCLEX anyway, NCLEX is going to focus more on the growth and development and the assessment differences and things like that. So I'm going to hit it like that. We're not going to go into a whole bunch of diseases. I think we're going to hit what's really peds specific, which is growth and development. And then Friday we'll do urinary, because I'm telling you, I'm brain dead on the second 2 hours, and I don't want to be brain dead for you guys. So we'll do that on Friday at this time. Let's see. So let's talk about peds in general. What are your strong strengths when it comes to peds theory? What do you guys think? What do you feel good about? Okay, I'll take that as not much. What do you remember from your peds semester? Let's go backwards that way.
I mean, I'm fairly okay with peds in general. I've done well on a lot of the peds and OB content. I would say though, I probably, like, even though I have a child of my own, it's still kind of hard to, like, the questions that they ask you when, what toys are age appropriate, because I mean, I have a, and I know we're not supposed to compare it to other people, but it's like I have a 2-year-old niece who plays video games with her brothers, you know what I mean? So it's kind of hard to differentiate that. And then, of course, as always, like, I know I can always use help on, like, Erickson. Actually, I'm okay with Erickson, but it's just maybe some of the other ones that aren't as common, like Piaget and Kohlberg and all that.
Okay. And again, I don't know how much in depth if you've only got 80 questions on, boards, I'm not sure how deep they're going to go into something like Piaget when it doesn't apply to all of your care, right, going forward. I think their questioning is more broad, oxygenation and things like that. And then for peds, again, it's probably going to be just more milestones and things like that. So hopefully that helps alleviate some of your anxiety about pediatrics, because it is its own animal. And you can get really down a rabbit hole with peds. Unless you're working in it, you really don't need to know all of that. And when you do work in it, you will learn it as you go on the job. So let's talk about assessment. So when we talk about growth and development, can someone define what growth is versus what development is? We always throw them together, but I want to make sure we all know what we're talking about when we say G and D, or growth and development.
Growth is like the actual, like, physical aspect of them, like height, weight, and everything, and then development is like the mental part, I guess.
Okay, good. So growth is the getting bigger, right? And that's pretty straightforward. We have ways to measure that. Development is the maturation, as they mature, as they become more functional, right? And as they become more independent. And that is development. So that's a little harder to measure in some ways. You can't put numbers to it, like pounds and inches, but development is still measurable, but it's just a little bit more gray, okay? Factors that influence either growth or development are varied. Like, there's a lot that can affect a child's growth, and there's a lot that can affect a child's development. We often put growth and development together when we say that, but they're two very different things, and they both can progress at different rates. So don't think just because you're delayed in growth, it means you have to be delayed in development, or vice versa. You can be completely growing fine, but still be lacking development. So just to clarify that. Genetics, unfortunately, play a factor in growth and development. You can't do anything about that. I always like the modifiable risk factors, right, that we can change. But genetics, it is what it is. And so, if you have someone with some genetic anomalies in their family tree, they're going to have like Marfan's or something like that, where their growth hormone is way off, or dwarfism. Those are going to be passed down, and there's nothing we can do about that. Prenatal What do you think about prenatal developing growth or affecting growth and development down the road? Even a 3-year-old or a 4-year-old, can that phase be affected by their prenatal care and course?
Yes, of course.
Of course, right? Because as that child develops and the neural tube is developed and all those things are developed, it's just a very vulnerable time. And so if something happens, if they're exposed to an teratogen, a med that would damage them, or maybe a hypoxic episode, or maybe mom got sick and it affected the fetus, all those things are going to develop or affect their development and growth down the road. Gender even affects growth and development. What do I mean by that? That sounds kind of sexist.
As far as puberty, women develop first.
Good. 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 And so that would be more of a development, right? Maturation. And boys tend to grow differently, right? They grow later in life as well. I know one of my friends played in the baseball for the MLB, and he had his growth spurt between 21 and 23. Like, he was short all through high school, and then now he's tall, but it didn't happen until he was finishing college, which is just crazy. Men grow and finish their growth spurt later than women do. We tend to kind of cap out with our height, at least. We kind of continually grow wide, but unfortunately, our height is determined usually by the end of high school or even mid high school. So those are just some things that will affect, and that none of that we can really help. Prenatal sometimes if we're really careful, but oftentimes things happen even prenatally that we can't control. Environment, so family and cultural. I mean, this makes sense. They've done twin studies since the beginning of psych classes and the science of psychology. And with twin studies, they've found that if you separate the genetic twins and put them in 2 different environments, they will grow and develop at different rates, right? And the environment is so very important in shaping and molding that child. Even growth. Sometimes we think growth is just, they're going to be as tall as they're going to be, but that's not true. Even the way they eat or the exercise that they get also affects the way they grow and develop. Socioeconomic, that makes sense. If you grow up impoverished, that just presents a whole different set of problems, maybe educational opportunities or even nutrition, those types of things. Living environment in general. Can also affect, stress, domestic abuse, those types of things. Parenting and relationships is huge. Maybe not so much with growth, but definitely development. You can very, very much have a stunted child because they don't have good, reliable, trustworthy parents and good, trustworthy schedules and routines and a good, safe place to live. That will affect their development as well. And then just that ties in with the physical and emotional health. Good care throughout their childhood is going to give them the best chance of having healthy growth and development. So let's talk about one way to assess a child's development, their maturation, is how they play. Okay, and there's a couple things that we look at to gauge milestones about play development. One is just their age. We know, just studying children for as long as we have, that children tend to gravitate and they have the ability to play in certain ways. So exploratory is that first year of life, and that's when, they grab things and they hold them and they look at them and everything goes in their mouth, right? That's just exploratory. That's all they can do at that age, is just explore their environment. I always, used to get frustrated when my kids would get into things at that age and pull out the pots and pans and I'd have to put them away, or throw the crayons around and you'd have to pick them up and put them away. But really what was going on, my mom was kind enough to say, you know what, that's her job right now. Like, her job is to explore the world and to figure it out. And yes, it's messy, but it's good. And you want her to be able to do that because it means that it's healthy and she's developing well. So exploratory is that first phase. Then as we get a little bit older, you'll notice, if you have children, that the things that they play with become mimics oftentimes of what they see the adults doing, right? Has anyone seen that before? Like, They have little tiny toy hammers and they're working next to their dad who's building a fence or whatever. They're always trying to mimic adults with their toys. Have you seen that to be true in your own kids? No?
Yes.
Yes. Okay, good. Even the little motorized cars, right? Like they want to drive like mom and dad, all of that. And that goes up to about 7 years old, where they really try to mimic their adult role models. But as they grow older and as they get into that real school age, they don't do that so much anymore. And they want to actually be competitive, and they want to do things that are creative and not just mimic. They want to figure out who they are and what they enjoy. So that's where like playing games and organized sports start to play a part. Hobbies, drawing or reading, those things that are actually more independent to the child's personality and bend. Okay, so that starts about 8 years old. You will see most kids playing the same way up until age 7. They all like to play kickball. They all like to whatever. They all like to imitate and play house and play bank and all those things. But once they hit 8, they start to develop their own interests, and they will start to kind of veer away from each other if they don't have the same interests and they don't play the same way. There's also social characteristics to play, right? And so as a tiny little one, they're just happy to be alone, right? They want to play by themselves. They like their own toys. They don't want to share. They'll stare at their mobile for hours if they're a good, calm baby. But as you get older, you're going to start to play. The play starts to look different, even socially. I always loved the toddler stage because we would get our kids together for a play date, and they would have a pile of toys in the middle of the floor, and we'd be drinking coffee or whatever, and you'd watch, and it was a play date because they were together, but they did not play together, right? They would each have their own toy, and they would still play very solitarily, but they liked playing next to somebody. They still didn't want to share. They didn't want to really interact, but they did want to be next to each other. So that's kind of the beginning of that social play. Okay, they're still not willing to share and to compromise and to coordinate efforts. Then, as a child gets older and they join peers more in a preschool setting or a more social play date, now they actually want to play more interactively, and they're more engaged with each other, and they try to agree on an activity together and all partake together. Typically, one person kind of rises above the cream and wants to be the leader. There's always that bossy kid in the middle of this group, right, in preschool, who's telling everyone what they're playing, what they're saying, how they're doing it, and everyone else just plays along. At the end of this, once you get into the school age, now we move into more cooperative play, where people actually have a say, they want to agree, and they don't just follow blindly just to have someone to play with. Okay, so those are just the two different ways we can look at play development and just kind of gauge where people are at and children are at. So if I have a 6-year-old who still very much is solitary, do you see where that might be concerning? Because really, a 6-year-old should be all about playing with someone and trying to be the leader or following the leader. That's where these come into play. Is it's good to know what you should be looking for. And I'll play off of, I think it was Danielle who said, you know, when you have children, you know exactly what that stage looks like. But once they move out of that stage, it's hard to remember. So that's why we're hitting this again today, because it is hard to remember all the stages when you're not exposed to them all the time. So now let's talk about growth. So we can measure height and we can measure weight. That tells us we have growth charts. You've all seen those, hopefully. And head circumference and chest circumference. Those are ways that we can quantitatively, with numbers, measure growth. Okay, so that's easy. If they meet the growth standards, we're happy. If they fall short, we need to work on that. And if they're even above, sometimes we want to work on that if there's an obesity issue. Couple things that we can use that are more quantitative for development gauging is a couple different screening tests. I threw them up here. I'm not sure you're going to really need to know them particularly, but it's good just to kind of think about. The Denver 2 only looks at kids up to 6 years old, and it looks at specific skills. So how do they interact? How is their fine motor, right? So how can they put the beads on the string and that type of thing? What's their language like? Are they developing language skills? And their gross motor, can they jump? Can they ride a bike? Can they walk backwards? Those types of things. This can be adapted for someone who's premature, which is nice. You can actually roll it back to know if that premature baby's still progressing correctly, because you have to adjust for that. But this is one way that we can actually look more at the 4 skill areas that are important to development. In contrast, the Stanford Binet is more about someone's ability to learn, which is fascinating to me. You can actually do this test and see, I don't want to say how sharp the child is, but how much potential they have to learn quickly. And so can they reason? Can they predict? Do they understand cause and effect? Can they process, problem solving skills, and how is their memory? It's fascinating to watch a child do a Stanford Binet test and to compare it to other children of the same age. So this one looks more at their cognitive, and the Denver 2 looks more at truly their performance, right? Questions on either of those screening tests? I'm sure you've learned about them before. Okay, you guys are quite group today. How else can we evaluate development? So we can look at their processes, right? Do they do things in a predictable sequenced order? Do they, go from step 1 to step 2, or do they try to start with step 4 and then go to step 2 and they're frustrated? We can look at their growth, of course, and growth is interesting. We used to think in science that growth was linear and it was this straight shot, as you grew, the line on the chart just gradually increased perfectly equal. And what some APNs doing their, I think, PhDs or I can't remember, their doctorate work, they studied, I don't know how many babies, and they asked newborn parents to log the nights that the babies had really fussy nights and they didn't sleep well. And these nurses that were working on their advanced degrees went and they measured every single morning. They never went on vacation. They never took a holiday. They went and measured the child, the length, every single morning. What they found was that the mornings following the fussiest nights, there was growth. Isn't that cool? So when we talk about growth spurts, it's really true. Babies and children don't really grow linearly in this nice, slow, even growth. It's usually in spurts, and growth hurts. So their hypothesis was proven correct that there are these painful growth spurts, and they were actually signified by these restless, fussy nights the night before. I just found that fascinating. I'll never forget that study. I read it in grad school. Any thoughts on that? Had you thought about that at all?
No, that's new to me.
Mm-hmm.
Keeping up with those fussy nights.
It kind of makes you thankful for the fussy nights then. You're like, oh, well, she's growing. Like, I can tolerate that. Her just being fussy to be fussy. Now that I can't tolerate. But yeah.
100%. Totally.
Yeah.
Especially after being stuck at home for months.
Exactly. So growth, that's just a fascinating thing. I got my master's a while ago. I would love to look back and see if there's more data supporting that, because that was pretty groundbreaking at the time. And then development, we can actually evaluate development by milestones and the tasks that they can actually perform. And we can pick up on delays if we're really astute, right? How often do we see our kids as they're growing and wellness checkups? It's quite often, right? It's a matter of every few weeks. When they're newborns, goes to every few months. It's like we're keeping a close eye on them. And then the best thing to do is to instruct our parents what to anticipate in the next growth spurt and developmental milestone spurt, so that they can be watching and making sure that their children aren't lagging behind the norm of developmental milestones and tasks. So that's kind of cool that all this has been put together for us to be able to evaluate their development. Let's see. You guys probably learned that the way that development occurs, at least with like controlling their own bodies, it goes from head to toe, right? And it goes from trunk to periphery. Does that make sense? So like someone has to be able to sit up with their trunk muscles and sit there as a 6-month-old before they can walk, and get up on their feet, right? So it's head to toe, the way they develop coordination and strength and control. And it's also trunk to periphery. They hold their head up before they can roll over, right? And so all these different ways of looking at, oh, this development isn't quite right. They're not doing things correctly. There's also gross to fine development, right? So they can crawl pretty early on, but they can't put beads on a string at that point in time, right? Because they're learning their gross development before their fine motor development. So this is, I always found this interesting. When you watch a baby, they fall into these as they develop and mature. So as a nurse, what do you do with all of this? Well, did you get to actually do your peds rotation in the hospital, or were you COVID bound by then?
I was able to do most of it.
Okay, so what kind of age groups did you guys have? Tell me about some of your patients. Ages or anything?
Our instructors tried to give us like a wide range of both. So like they kept track, like if we had a 3-month-old one time, we had like a 4-year-old the next.
Good, good. What was the same with all of those? What was something different you didn't have to do with an adult, but you had to do with all those different ages, Haley?
I don't know. Is that a trick question?
So look at the first point I've got under nursing care.
Therapeutic. Oh.
Right? Because, you know, when you go in to take care of an adult, they understand why you're there. They understand that it's already an implied relationship. There's going to be trust. There's going to be this and that. But with a child, I mean, we have to spend, and hopefully you experience this, you have to spend some time earning their trust, developing their relationship. You know, they won't let you look at them, let alone touch them, if you don't do that. So that's very different for the pediatric world. You have to establish that trusting relationship. I'm sure that you experienced that. How did you build a trusting relationship with some of the kids that were more resistant to you? Did you have any problems with that?
Oh, absolutely. I don't know. Mom and dad were usually in the rooms. They were like a little like introduction. It was kind of like the mom and dad were like, it's okay. She's not going to hurt you. Like the mom would explain it or something. So that made it a little bit easier, but some of it was more challenging. Like if the parents weren't there, you just kind of had to go in and like hang out for a little bit and let them get used to you.
Right, right. I always found, I worked peds for quite a while, I always found just playing with them first a little bit, either playing catch or letting them squirt me with a syringe full of water. You know, they always found that to be fun. Once you broke the ice with play, it seemed like they could relate better. So yeah, very good, very good. So when you prepared for peds, hopefully you had to do like a developmental sheet that said, oh, the 6-year-old should be doing all these things. And that would put it fresh in your mind. So when you were caring for the child, you could assess that kind of ongoing as you were in the room. Assessing a child typically isn't a one and done like it is with adults. Adults, you're like, I'm going in to do my head to toe, and I'm going to come out with all the information that I need. Rarely does that happen in peds, right? It's over the whole shift that you gather information and you observe, right? You might get your vitals all in one shot, but the rest of it, watching them interact, watching them play, watching their coordination, all of that takes time. It takes being in the room more than with an adult. A lot of education has to happen with parents. Parents are all over the board with their knowledge of their child, right? So you got some that have read every book, they're on every blog, they know exactly what they expect out of their child, whether it's right or wrong. Others really don't, they weren't parented well, and those patterns are repeating themselves in this generation, and they need lots of guidance, even about things that you and I would probably take for granted, like they need to go to the doctor when they're not sick. That is actually quite a concept for some people that only went to the doctor when they were sick. To have well visits and pay for them really doesn't make sense to a certain population that we care for. So we need to make sure they understand that. We need to make sure they understand immunizations and the diseases that might come along and what they look like and when to call the doctor for them. Diet is a big one. Think about how they progress from breast milk or formula all the way through a diet, the choking hazards, the nutritional needs. Most parents don't have that information just naturally occurring. You know, in the things that they're reading or watching. So lots of education, lots of education. How to keep the child safe is another big thing, that you can't sleep with your baby and the car seat has to face backwards and all those kinds of things. If people aren't told those things, there's no way they're going to innately know them. Okay. We also have to watch the parents for their parenting. That is actually our job, and it feels weird and it feels intrusive and you feel like you're the police, but part of being in that room is assessing that relationship and determining if you feel like that child is safe and cared for, okay, and not neglected or abused. So we have to really be aware, not just of how the child's behaving, but how those adults are behaving too. Did you guys run into any parent issues while you were on PEDS? No? Oh man, you had some
No, I didn't.
good experiences. When I worked there, it was like the worst part of PEDS was the parents because none of them seemed to cooperate well. You've got the helicopter mom who doesn't let you do anything, and then you've got the one who doesn't show up for 6 months, and then finally comes to take their child home once they're better, kind of thing. Or the abuser that sits at the bedside who hasn't been convicted yet. Those things create hardship. And you have to be careful. You're a professional, so you have to just treat them with respect because you don't want the child to see you disrespecting the parent, or you'll never earn their trust. So it's a fine line that we walk when we care for these kids and their parents. We want to always do those screenings and document them well. We want to promote socialization and activity and play. That is their job. A child's job is to learn and to explore and to trial and error and all those things. And when they're in a hospital, it's really hard to give them opportunities to interact and to play. So we do have a playroom on PEDS floors. We have activity specialists that are just absolutely wonderful that'll go in and help to match up activities and toys with the child, and try to get them socializing if they can, if they're not infectious. So yeah, lots and lots of things we need to do to promote those 3 things. They're so important. They're foundational in a child's life: socialization, activity, and play. Okay. Sometimes we have to get creative, but we can if we put our minds to it. Then we also have to meet those basic needs of safety and hygiene and rest and all those things as well. We become almost second parents to these kids, especially if the parents are absent. Okay. So how do you know you're doing a good job of caring for your pediatric population? Well, you need to make sure that each child is meeting their growth and development. What do you think you do when you notice a lag in development or maybe a problem with the growth charts? What's your role in all of that? Myra, are you out there today?
Yes, ma'am.
You're awful quiet.
I know.
I was going to ask you to repeat the question, actually. I couldn't find my mute button.
Yeah, thank you. So, you're monitoring this child who's in your care, their growth and development, and you start to see lags or you start to pick up on milestones that aren't being met. What's your responsibility in that?
To educate them.
Okay, good. Educate.
Depending on how severe the lags are, maybe reporting them to their pediatrician or healthcare provider.
Right. So documentation is key, and always, no matter how mild they are, if it's abnormal, we report it. Okay, because typically the start of an abnormal gets worse. And so we want, even if it's early and you're not quite sure what you're seeing, you still want to mention it to the provider because they need to be aware, because they're not in the room more than 30 seconds, right? They visit, they kind of talk to the parents, look the child over, touch their belly, listen to their lungs, and they're gone. They're not going to pick up on those things the way we do when we care for them for 8 or 12 hours. We need to really make sure that the parents have a good understanding of milestones. How do we do that practically? What are some things we can do?
Ask open-ended questions about their belief and values on how they care for their child.
Good, good. Open-ended questions are the best. I learned that early on. You cannot ask yes/no questions and get any information at all. Very good. Open-ended questions. Are there tools that there are out there that we can use and maybe give?
Like maybe give them some toys or things to play with and see how they do it and point out to the parents, like see what they're doing right there. Like the pinch or grasp, something like that, so they can actually physically see what you're talking about. Because I know
Good.
as a new parent, like I didn't know what the pinch or grasp was until, I started school. So
Right.
some of those things where there's no other way to explain it through other than medical terms.
Right. Very good. Yeah, that's really good. If these parents don't know what to look for, they're not going to pick up on the deficits. And what if that child doesn't come back for 6 months? That's 6 months that we've lost that we could have worked on those deficits, right? So yeah, very, very good. There's also, back in the day, I mean, my youngest is going to be driving here soon. My oldest is 25. Back in the day, my pediatrician would give me just a simple one-page sheet of paper that would say anticipatory guidance. Did you guys learn about anticipatory guidance?
Yes.
Yes.
Okay, good. So that is, you're at your 6-month checkup. They're going to give you information up to the 9-month checkup. So between 6 and 9 months, you're going to start to see, or you should see, your child rolling over, should start to be sitting up, holding their head up, and trying to grab things with their fingers. So that anticipatory guidance is just a list. And I remember magneting it to my fridge and just having it there. And I would look it over every once in a while to make sure that my children were doing what they were supposed to be doing. That's a great way, because no patient or parent is going to remember everything you tell them verbally, but give them a piece of paper and they've got it forever. Okay. And then we just want to make sure that if there is anything negatively impacting growth and development, that we address it. So if that's nutrition, if that's a stressful home life, if that's an abusive parent, we need to really make sure that those things are addressed. Okay, so that's just the basic intro to peds. Let's do some questions. Here's the first one. Anybody else? Okay. So here are the results. Now, red does not mean right. Red just means it got the most votes. Someone who picked C, explain your rationale, please.
I thought that the eyes, ears, and nose would be the most intrusive, which might cause the most reaction and throw off the results of the exam. So I wanted to do that last.
April, you're right on the money. So children have very keen sense of their intimate space. Like they don't want you in their space at all. If you try to step toward a 2-year-old and go straight for their eyes and their mouth, it's very intimate to them and it's very, very intrusive. So you have to build a relationship with them and get them used to you being there and you examining them. So you start with their back and their arms where it's just not as challenging, it's not as threatening, you're not as intimate with them. And then you work toward the eyes, the ears, the nose, and the mouth. Good job, April. That was perfect. Does everyone understand why you got that one wrong?
Yep.
Good. Good. Okay, let's do another one. Anybody else? Okay, this is interesting. We've got it pretty evenly spaced here. Someone who voted for D, tell me your thinking on that and why that's better than B and C.
Safety's priority with smaller infancies.
Good. Isn't safety the priority all the time with everybody, really? I mean, safety is one of our very cornerstone of nursing, is safety. Very good. Why is C not a good answer? Wouldn't holding the knees flat kind of provide some safety?
No, probably cause tension and to the baby where she's fussy or he.
Okay. It'll cause them kind of to be irritable, right? Holding them down. Plus, what does that do to the scale?
Puts pressure on it.
Throws off the scale measurement.
Yeah, it does. Very good. Very good. And then is covering the scale with a clean piece of paper a bad thing? No. But is it the priority? No. Keeping him or her from diving off of the scale onto the floor is the priority. Does that make sense to everybody?
I struggle with this one because I chose C because they usually at the pediatrician's office they will do her length and then take her out to the scale, and they've done that ever since she was a newborn, and they would pull her leg straight and pull down her leg so they can get an accurate measurement and then measure her at the head.
Gotcha. But this, yeah, okay. Yeah, that
I've
makes
never
sense.
really seen something like this, so I guess that's why I didn't choose D.
Yeah, yeah. So the key here, Danielle, is the highest priority, right? The highest priority is usually going to either be an ABC or a safety, right? So very good. Good discussion. Here's another one. Okay. Why is B the best answer over D?
Comfortability with the placing the measurement and an accurate measurement when you get it right above.
Right. Yeah, the standard is we go above the eyebrows, so over the forehead, and which is the widest place of someone's head, right, is right there. Below the eyes, well, that's not the way that it's done. So it's just as easy as that. Very good. How about this one? Okay. So tell me what you were thinking about when you read the question.
The
Nonverbal indicator of pain.
I'm sorry, what?
Nonverbal indicators of pain.
Okay, nonverbal indicators of pain. And just pain. Like this has to be not a if maybe situation. This has to be if I saw this in a child, I would assume that he's having pain. Does that make sense? No ifs. Well, yeah, maybe. No, if. So it's just if I see this in a child, I'm going to assume that they're in pain. So A, pulling on an ear. What do you think?
Yes.
Yeah.
Absolutely.
Action.
Good. What about pale oral mucosa?
No.
What would you think if you saw pale mucosa?
maybe
Or circulation, possibly.
dehydration. Yeah.
Good. You would think perfusion things, right? So if you picked that one, you were probably going down an if maybe road. Like, well, maybe, well, if. How about C? If someone was vomiting formula, would you think, oh, they're in pain?
No.
Okay. Could you go down the, well, if they're in enough pain, it'll make them nauseated and maybe they'll vomit, right? So that's not a good answer. Cries, even when being held.
Yes.
Absolutely. If someone was inconsolable and they couldn't tell you they're in pain, you're going to assume they're in pain. What about turning their head from side to side?
Yes. Ear infection.
Yep, exactly. Or a headache, right? Trying to get away from the pain. So does that help you guys? Those of you who picked B and C, can you see why those were not good answers of indicating pain? They could be all kinds of other things and maybe not even pain. Here's how you guys broke it down. So A, D, and E were the answers. Good discussion. Whenever it's asking a question like this, you're going to want to just hone in on the pain and not anything else. Good. Here's another. Okay, here are the results. What do you guys think of these results? Someone actually picked E.
Baby reverted back to regression, I would say.
Okay. A 3-year-old who sucks his thumb? Maybe. maybe. What's going to happen? And I always ask myself, when you have a choice of what you can say or what you can do, like what's going to be the result of what I say or do? What's going to be the result of A?
Might make them, I picked this one, but now that I'm looking at it, it might make them even more upset bringing up the fact that mom's gone.
Right. We finally got her over it. And then we're going to remind her mom's gone. Like, that's probably not the best thing to do. She's going to start wailing again. What about B?
I think that again will remind the child why she was crying.
Oh, yeah, I was crying, right? And then again, do you miss your mom? Yes, I miss my mom, right? So the best thing is just stay the course. She's calm. Let's just reinforce that good behavior. And D is the correct answer on that one. Does that make sense? She got over her stress, and then we're going to reignite it again by bringing up why she was stressed with the first three. Any questions on that one?
No, but breaking it down like that, I realized like, wow, because I just honestly, I jumped to A.
Right. So you got to think like, okay, what is going to be the result if I choose this one? How will she react if I choose this one? The safest choice is just, should I read a story to you? Unless like her mom read to her all the time, that might trigger that, but that's the least challenging statement that you're going to have to choose from.
My other question is,
Yeah.
with that one is like, I thought we were supposed to be staying away from the do questions because it gives a yes or no, or is that like for the children that be probably effective?
So a 3-year-old is really good at answering yes and no. They really have a hard time with open-ended questions developmentally. They can't express themselves very well yet, right?
Right.
So, when you're not really assessing her, right? Yes, or open-ended questions are good for gaining more information. Are we looking for more information from her, or are we just trying to communicate with her?
Communicate.
Yeah. Yep. Yeah, good. All right. Before we go on, let's take a break because that was a long hour. And then we'll come back at 10 after and we'll do some more growth and development stuff. 10 after.
Sessions. So are we have 2 sessions left or 3, and how are they divided out? Because I'm kind of confused.
You mean this is our last week.
Okay, that's what I thought.
Yeah, unfortunately. So we'll do 2 hours today. Professor Moore's doing her 4 hours tomorrow, and then I'll finish up my 2 hours on Friday.
Oh, okay. So this is our last week. It'd be 3 days of this.
Yeah.
Okay.
Yeah, the 4 hours is killing me, and I'm pretty sure it's killing y'all too. So
Okay.
I thought I would try it this way because going forward, I'll be teaching this year after year. I want to see what's best for everybody. So
Okay.
yeah, at some point you become oversaturated and you become brain dead. So, and I do too. So.
Okay, cool. Okay, thank you.
Yeah.
Will the videos be available for the next couple weeks also for us to refer back to?
Yeah, I have no reason to pull those down anytime soon. Yeah, no, help yourself.
Thank you.
You're welcome. All right, let's dive back into the rest of PEDS. Okay, so I'm going to hit these developmental stages. Just to give an overview, you're not going to have to remember all of this, I don't think, but it's good just to have a good review. So when we're talking about assessing an infant, and an infant goes up to 12 months, right? 0 to 12 months, or I guess 0 to 1 is a newborn, but an infant is 1 to 12 months. We're going to assess their growth and development and look for milestones. And we're going to figure out and make sure that there's good attachment during that first year. Can someone define attachment for me? Okay.
It's socialization. Basically, it's what you see. There's things that are healthy with that you can see if it's going well with that.
So bonding, right? We're talking about bonding with parents, siblings, and attaching to that family. Very good, very good. Because sometimes you will notice that babies don't attach to their parents. That is a telltale sign that something is very wrong. Because by nature, parents and babies typically will attach within that first year without any trouble. As long as the parents see the needs and meet them, there's going to grow this attachment, that trust versus mistrust stage of development. So if we don't see attachment, then we know that we need to dig a little further and see what's going on. There are all kinds of different things out on the net that I've just kind of looked through, but this kind of helps. These are good things we can even give our parents, right? That would say, hey, this is what you should expect, or this is what should be going on. This wasn't a good one that I found. You do not have to memorize this, of course, but it gives you a good idea of some tools that we can be using or giving. I like visuals like this because not everyone is literate, and so the pictures really help on the left side of the screen. Okay. So when we're assessing, we're always assessing to look for problems and to diagnose, right? So when we're assessing an infant up to 12 months, our biggest things we're looking for are typically injury and failure to thrive and developmental delays. Those are going to be the three things that might show up as abnormal in an assessment. Injury, of course, because they're so very vulnerable, right? They're totally dependent and they don't have good judgment. And when they do start to move and roll, they can roll off of a couch, they can roll off of a counter, those types of things. Failure to thrive, that can be emotional, or that can be just malnourishment. And then developmental delays, we're watching for all those milestones that first year. What can we do? We screen often. So during that first year, you know that the wellness checkups are quite frequent, and we're going to keep an eye on that. We're going to make sure that the relationship between the parents and the child it's strong and they're bonding well. We're going to start to do that anticipatory guidance with the parents and give them information as to the next milestones that are coming to make sure that they're meeting those and watching for those. Selecting age-appropriate toys is always hard. Someone mentioned now we've got 2-year-olds who play on phones and tablets and Xboxes. But when they don't have those electronic things, what normal toys are appropriate? Another teaching point is we don't just introduce all foods at the same time. You know that we introduce one food at a time, and it says for 2 weeks. That's a long time. Practically, I don't know how many people actually do that, but that is our guidance. Okay. We'll give the least allergenic foods the first half of the year, and then the more highly reactive foods the second half of the year. So the first half of the year, what kind of foods do we start to introduce to an infant, like the first 6 months of life? What are the first things we start with?
Cereal.
Okay.
I know sweet potatoes is one. Peas, like mostly you try to do your vegetables first, because if you introduce fruits first, then they're going to be more inclined to only eat fruit.
Right. So the not sweet things first. Good. And then as far as grains go, rice is the least allergenic, and then you can move into the wheat later because that has a higher incidence of allergies. So we'll just introduce foods really slow. If you introduce more than one food at a time, you don't know what's causing your reaction if they do have a reaction. We'll also look for separation anxiety. Is that a bad thing? If they have separation anxiety, does that mean there's something wrong?
No, not necessarily.
No, developmentally, we just went through that stage of trust versus mistrust, and they've learned to bond with us and depend on us. And when we're gone, that should rattle them a little bit, right? Now, they shouldn't be inconsolable, but they should have some sort of angst when the parent leaves. Good. Moving on to the toddler assessment. So we're going to do the same things. We're going to still watch their growth and development. We're still going to look for those milestones, but now we're going to make sure that they start to show that independence. I remember my oldest, who's now living on his own in Chicago, 25 years old, he would always say, me do, I do it, me do it, right? They want to be independent. They want to be big kids. So we want to look for that and make sure that they're developing toward that. As annoying as that is to the parents, it's a good, healthy thing. Here's another type of chart. You probably can't see it, but I just wanted to show you there's all kinds of different resources out there to give parents, or even for yourself if you're a new peds nurse, right? That tells you what a 2-year-old should be doing, what a 4-year-old should be doing, or whatever. Okay, so that's just another tool to show you the variety. What are the common problems in toddlerhood? Well, safety is huge. They do think that me do it, and they do think that they're bigger than they are, and they don't think through consequences. So, and their melons, their heads are so big and heavy at that age, right? Their heads are disproportionate to their bodies. So oftentimes when they fall or trip, their head bangs against something. They also are negative, right? What's their favorite word? No. Let's brush your teeth. No. Once they learn that no, and that they can exert their own free will, then they're going to use that a lot. So that's something that parents need to be coached on how to parent that and discipline that and work through that. Abuse is common in this age because they are a frustrating creature, right? It's like having a puppy who's always into things and chewing things and causing problems and making messes. So abuse is high during the toddler stage, unfortunately. Parents get very frustrated. Nursing care for them. The screen for growth and development often is going to just stay on the nursing care screen for all these stages. We're still going to watch their relationship. We're still going to give anticipatory guidance. We're still going to select good toys for them, right, that challenge them, but they're still safe. And then we really need to help the parents develop routines for sleeping, feeding, and playing. Toddlers are notorious for just bucking the system and trying to get away with whatever they can. And oftentimes, this is where the relationship turns in a child and parent relationship, where the toddler somehow throws enough fits that they get the upper hand and they become the boss and they carry all the power. And that is something we cannot condone, right? They need guidance, they need schedules, and they need routines. So we need to encourage the parents to stick with it, even though it's hard and even though it's a fight every single time you make them do anything. They need stable routines. Okay. Preschool is from 3 to 6 years old before they go off to first grade or kindergarten. And psychosocial development begins as well. So now they're starting to understand there's a difference between boys and girls and all of that goes along with it. We're also still going to be assessing growth and development. Here's a different type of table for a preschooler, and it's kind of nice. It breaks it down into fine skills and growth skills and what they're able to do. Just some more resources. You'll see that from 3 to 6, there's huge developmental, like fine skills. A 3-year-old can pick up a block and maybe put a shape in a hole, but a 6-year-old can actually build a tower and hold a pencil, right, and tie their own shoes. That is huge developmental growth over those 3 years. Problems with the preschoolers, fear of injury. So now they've fallen down enough as toddlers that some preschoolers become very scared and they don't want to climb on the monkey bars and they don't want to ride their bike because they're scared. They know that if they fall, it's going to hurt. They're also fearful oftentimes of punishment, especially if their parents aren't good disciplinarians. If they are, prone to rage or to abuse, even just verbally, that will cause some children to fear punishment and avoid it at all costs. Safety is still a problem with the preschoolers because now they're getting a little more independent. They might be playing a little rougher, maybe chasing a ball around or wrestling, jumping off of things. So safety is always an issue with the preschoolers. And they're starting to socialize and work together and play together, cooperative play, but that comes with its own problems, right? Because we've got strong-headed kids all trying to work together, so they might have difficulty cooperating in a group play situation. They learn a lot of social norms in preschool, how to play, how to share, how to be quiet, how to not touch each other, those types of things. As far as nursing care, they're all the same, age-appropriate toys, anticipatory guidance. The routines still need to stay in place. Now, those routines will change and morph as the child gets older, but they will still need to have some sort of routine. And then the idea of parents as role models. This is where we start to transition just a little bit from authoritarian, right? You have to be authoritarian when your children are tiny. But as they grow into their own little selves and they start to socialize more and they're away from you more, we have to infuse a sense of morality and right and wrong, and somehow get their hearts to be in tune with what is right and what is wrong. We can police behavior as parents, but that's not effective, right? We have to police their hearts and their motives and why they're choosing what they're choosing and why that it's not good for society or good for them or whatever. So reinforce that idea that now we're starting to give them a little more control over their environment. School age from 6 to 12, so this is before they head off into like adolescence. We're going to look at all these same growth and development things. They're very industrious at this age. This is when my daughter just started drawing and writing and reading, and they love to build things, art and all of that. Logical thought patterns, they can actually now sequentially reason, like if I do this, it's going to end up, you know, here. They can actually do prediction and see patterns. Peer relationships become much more important, in fact, sometimes too important, and so parents have to rein that back in and make sure that they're not being unduly influenced. It's really hard with social media. You have to really do some teaching with parents about that because of the undue influence, bad usually influence of social media influencers. Likes and dislikes are established. They're not just going to like spaghetti because their friend does. Now they actually are going to decide if they like it themselves. This is a pretty good school-aged breakdown of psychosocial and psychosexual and the things that's going on in them. Okay, they can move into a more abstract world and actually be able to predict and reason. This is a fun age, actually. This is a fun age. Whenever I taught VBS, I like to teach in this age because they still were wanting to please you, and they weren't too cool for you, but they could tie their own shoes and wipe their own nose. So this is a really fun age. What happens in the school age years, though, vulnerabilities do pop up. So enuresis, so bedwetting could still be a problem that we would need to deal with. So this would be a question maybe we would ask during a wellness checkup if this is occurring. Safety is always an issue now. In school age, they're actually playing maybe some competitive sports, so you'll have lots of sprains and bruises and things like that, maybe even bone breaks. Body image has become an issue, and I think that's due to a lot of social media influencers. And it's not just a girls problem. Boys are really starting to feel this body image thing too, and it's just really sad to see the kids gauging all their worth on how they look or how they think. It's actually how they think they look. Social interactions are growing. They're going to want to be away from their parents more and more. That is natural, but still have to be kept safe and have good boundaries in place.
I have a question about enuresis.
Yeah.
About how, I mean, what is like the average, if there is an average age for that to kind of just go away or be resolved, or, I mean.
So it becomes,
I'm just curious.
It becomes, I love the sound of your kids in the background. It's perfect.
Sorry.
Oh, it's awesome. I think he was barking or something. Anyway, so it becomes a problem. You have to think about it just not like, is it happening, but how often? Is there a pattern to it? Maybe the parents are giving, you know, and I have a hard time believing this, but it happens, giving them Coca-Cola before bed, right? And so between the fluid and the caffeine, that now they have bedwetting. So it has to be assessed pretty deeply as far as frequency, pattern, and that kind of thing. If it's still occurring once they're in school, if they're in, you know, kindergarten or first grade, it will be looked at. Up to that point, bladders just aren't mature yet, and the neurons and the nerves that are innervating it can be immature. So there's not a whole lot of worry until you get to that age where they're maybe 6 or 7 and it's still occurring without a good reason. That's when they start looking at maybe medication or things like that. Does that answer
Right,
your
because
question?
I'm just, yeah, well, just because, I mean, I know of a 10-year-old who is still in pull-ups at night.
Yeah, so
and I was just curious.
something, yeah, there's something to look at there. It could be emotional, it could be physical, it could be, you know, different. The pediatrician should be diving deep into that and figuring that out, because 10 years is really quite old to still be in pull-ups.
That's what I thought. So I just had to ask just for
Yeah.
my
Good question.
knowledge.
Good question. Good question. Encourage physical activity. You know what? Yeah, we never had to do that when we were little. We were always outside, right? But now they're all on the couch playing video games. So we really have to encourage. Encourage isn't even the right word. I have to force my kids sometimes to go get some physical activity. So that's something to think about. Adolescence. Now, adolescence can be a whole lot of fun. I loved my kids in this age. They weren't rebels, so that helped. But it could also be a really hard time. And so from 13 to 20, you know, so much is going on. Their body image is super important. Their peer relationships become much more important than their family relationships, because that's where they draw their identity and their worth. They really want to be autonomous. 13-year-olds really think they know more than you do. They really do. They're not just trying to make themselves think it, like they really believe you're stupid at that age. That usually resolves when they have their own first child. Then they realize you weren't so dumb. But these are the problems that you might run into with adolescents. Here, this is kind of blurry, but just to show you, there's still, even this age group has good resources of adolescent development. Problems in adolescence, we can just run through probably 100 different problems that could happen, but the biggies are pregnancy and STDs, poor self-image, suicide is really, really high, coping skills are lacking, safety, again, these are risk takers. They think they're immortal, and they see things in the media that people are doing that they think that they should be able to do too. They're driving now, which scares the crap out of me. When my kids are 16 and starting to drive on their own, they are oftentimes with their peers and doing things they shouldn't be doing, like substance abuse, violence, you know, gang activity, all kinds of things creep up into the adolescent development that can really affect the rest of their lives. What can we do for them? A lot of this is the same. It's funny that we say select age-appropriate toys, but still, right? Video games, you know, do we get them a dirt bike? Those types of things. Should they be able to have a four-wheeler or whatever? So it's still appropriate to look at the toys that they're using and playing with. We still need routines. I know 13-year-olds think they should be able to be up all night on their phones, but they should not. So routines are still important. Meals around the table are still important to develop those bonds. Encourage higher education opportunities and options. This is where, you know, it's not out of line for a pediatric nurse to say, hey, what are you going to do after high school? Are you thinking about that? What plans are you making? Sometimes you might be the only one speaking that language. Maybe there's never been anyone that went to college and it's never been on this child's radar. You can mention it just in a brief interaction and change the course of that life. So it's something you probably hadn't thought of, but it's a really good thing to bring up. Okay? And then helping kids know how to resolve conflict. They're going to resolve conflict the way their parents resolve conflict. So if they saw screaming and door slamming, that's what they're going to do. If they saw fleeing and running and leaving for days, that's what they're going to do. If they saw fists and kicks, that's what they're going to do. We need to promote healthy conflict resolution, okay, with these kids. And you can ask those questions. Hey, what happens when you get angry? How do you handle that? Those are fair questions. Okay. Any thoughts on anything I've covered so far? What's your takeaway from all these different age groups?
A lot of a lot of similarities, yet very detailed specifics on each age group, which would probably be a lot easier to focus on the differences than the similarities.
Oftentimes, nursing theory, like when I teach respiratory disorders, I just teach them the differences, right? Because the similarities are the similarities. You're right. So what makes this COPD versus pneumonia, right? Because they both look the same to the person who's not oxygenating. So you're right. Look for the differences. That's good. That's good. Let's do some questions. Anybody else? Well, you all got that one right. What's wrong with the first three answers?
You never want to like lie to them because there is something to worry about and you will feel pain. So you want to be honest with them.
Very good. And D is beautiful because it gives them some control. They know that you're being honest because you'll say, and we can do something about your pain, right? And we can alleviate your pain. You're going to have pain, but we can do something about it. That builds trust and confidence. Good job. Good job. Good job. Anybody else? Good job. Vital signs are the priority here. Now, if there were other choices, vital signs might actually not be the priority. What might trump monitoring vital signs post-op?
ABCs, anything that has to do with airway.
Good.
Breathing.
Good, good. ABCs, maybe safety, right? Those things. Good, 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 good. Very good. Here's another one. More than 4 of you are going to answer this. I'm going to sit here until some more people take a shot.
Yes, hold on just a second. I'm gonna answer. I got called away for just a second.
You're fine. Thanks.
Yeah.
There's, okay. All right, this is interesting. Let me show you what you guys think.
This was a tricky one. I thought it was a select all that apply.
Ah, okay.
I mean,
So,
I only chose one, but
right, right. So let me paint you a different picture that's not medical. So my husband takes me to a resort in Mexico, and the hallways are painted really nice, and you know it's got SpongeBob on the wall. Someone I'm familiar with. Okay, that's great. So the people wear really nice clothes, and it's fun to watch them while they're working. And there's shuffleboard, and there's parasailing, and all kinds of fun things that I can do. Okay, but when I'm in my room, I'm not sure someone's not going to come in and torture me whenever they want. Am I going to feel comfortable and safe just because of the environment? See where I'm going with this? These kids need to have a place where they can relax. And if we are doing IVs while they're in their own bed, and if we're doing NG tube insertions while they're in their own bed, they will never relax if they know that people can come in and hurt them. Does that
Out
make
of
sense?
curiosity, and I was looking at that one because I was kind of
Me
thinking
too.
along the same lines. But have you ever seen that practice outside of in theory through test questions? Because even at OSF, in both of the ER and in the pediatric units, everything is done in room. For doesn't matter if they're babies all the way up to 18.
right, urinary catheterizations, all that stuff is done in their room.
Yeah, no, when I worked there, and I worked there for years, I always used there's a procedure room on 6 Mile that we always used for anything. If nurses now are being laxed on that, that's terrible. That's awful. These kids would never relax. This way they could know, okay, as long as I'm in my room, nothing painful is going to happen to me. So if that has laxed, that's really sad because that was never the practice before. We always, now in the ER, that's a little different because they're not going to live in the ER, right? Like they can torture you all you want while you're there 2 hours. Once you go to your room though, you should be able to relax and feel safe there. That's sad that they're not doing that.
I mean, like personal experience, my daughter had to be hospitalized at 6 months old. She's just now turned 2, but she had to spend some time at G200, and they did she ended up having a UTI. So they had to do a VCUG and put in a urinary catheter, and they did like 4 insertion attempts in her room.
Oh. Yeah,
they did her IVs in her room. They did everything in her room. And when she was a brand new newborn up in the Milestone Pediatrics, they did everything in her room. And that was just 2 years ago.
Newborn I can see because newborns don't know where they are, right? They're just clueless. But when you get into that toddler where they understand, you know, when they can be like safe, when they're home they know they're safe, or when they're in their room they know they're safe. That's just sad because they would never be able to relax not knowing the next person that walks in the room is going to hurt them or not. My rule was I'll do their vitals in their room, vital signs and assessment, but if there's anything even remotely uncomfortable or dangerous, we're going to a different room. Wow.
Right. So I guess that's kind of like the rationale as to maybe why Nicole and I don't know which one she chose, but that's why I chose D. Okay. Is because the playroom, because I know you had said before in this review session that activity and play are some of the most important aspects of the child.
It is.
Yeah, that was my rationale also, is just because like I liked B, but I've never seen that in practice on any of my times, either in the hospitals with my children or up on the floor as a student nurse.
Agreed.
Okay. Well, don't go on your, most of our experiences with old nurses are probably not textbook. They're probably not NCLEX worthy, right? Like nurses find loopholes, they find ways to be lazy, they find ways that, are not evidence-based to carry out their tasks. This question is just asking what would most likely support the child. So that's where, it's not what have you seen, but just in theory, what would make the child feel the most secure. So yeah, good discussion, you guys. Let's do another one. Oops, one there. Someone who picked C, share your thoughts. Why is that one right?
Safety relates to the side rails while the child is being in the room needs to
Okay,
be up.
good. And is there opportunity for them to be left down with all that going on?
Yes, I
Yeah.
chose that one just because I feel like that is the most common thing that I feel like would be occurring, because a lot of people I feel like would probably not have a ton of things in the room, but beds in and out would be a constant thing.
Right, good, good, good. A is assuming that they have safety locks at home in the first place, and many people actually don't. So A is assuming an awful lot. Plus, we typically in peds still keep stuff locked up or at least high out of their reach. So that's really not the biggest concern. D is assuming that there's no parent at the bedside. So there's assumptions going on in A and D that make C the best answer. Good job. One more, then we're going to call it a day. Good job, you guys. What do we call the thigh muscle that we give that injection into?
Vastus laterals.
Yes, Myra, the vastus lateralis. Good. That's the biggest muscle that they have as a 3-month-old, other than their buttocks. We don't do that because of sciatic damage. So very good, you guys. Made it through another, well, a half a review, right? I guess I had a couple extras. Let's do one more, and then we'll call it a day. Let's see. Let's do this one. Okay. Here's the results. So what makes A suspicious?
Humor and fell down the stair steps.
You don't think a 10-year-old's capable of falling down the stairs? Or
Oh, well, yeah, no, sorry.
yeah, what makes 10, like, if you heard this story and saw that break, you would think, oh, that can't happen. That has to be abuse.
Well, just because of falling down a set of stairs, running into a door, that kind of thing, that's usually like your common excuses for injuries during abuse.
Okay. Yeah, they fell down. Like, that's a common excuse for a lot of different injuries. But is that enough to suspect it necessarily? When you're looking at abuse cases, you have to figure out if it matches up. Does the injury match up? Is it possible it could be caused by the story, right? And so falling down the stairs can actually cause a simple fracture of a femur. Like, that is logical. That can happen. Now, you know, it could be not true, but it's at least possible. The reason B is correct is a spiral fracture. A spiral fracture of the arm, of the humerus, is when, can you guys see it here? Let me stop sharing for a second. Is when you actually have a twisting of the bone and it splinters, and it's called a spiral fracture, okay? That is actually from someone taking the bone and actually snapping it in a circular, like a rotation. So let's go back to the question because I already forgot the whole question. Saying that a spiral fracture was occurred from a bat that would have caused a simple break. It would have just caused a fracture. It would not have caused that splintering and spiral effect. That spiral fractures, there's really no good mechanism of injury other than someone abusing the child and doing that to them. A car accident typically doesn't cause spiral fractures. A bike accident doesn't. Falling off a trampoline doesn't. When you see spiral fractures, the first thing you think is abuse. Okay. Those of you, the 5 of you who picked it, you must have known that.
Well, I just know that spiral fractures are caused by a twisting motion in a baseball.
Yep.
That's not going to do that.
Yeah, and so the story did not line up with the injury. That's the thing with abuse. You have to be able to say, nope, there's no way your story would have created that injury. That's when you start to think abuse. Very good. Very good, you guys. All right. So PEDS is in the books. We'll do renal on Friday. You'll do whatever you're doing tomorrow. What, OB maybe with Professor Moore? Sound good? You need
I have
anything?
no idea. I don't remember what we're doing tomorrow with Professor Moore.
Do you need anything else from me?
I do have an off-topic question.
Yeah.
Has nothing to do with school or anything, but I saw your Facebook profile.
Yeah.
Do you know Ben Zobrist, or
Yeah.
did you just get a chance to meet him?
Yeah, no. Yeah, no. I watched him grow up actually, and I've sewn some of his uniforms and stuff. Yeah, it's kind of fun. Watching him.
Jealous.
Yeah,
so jealous.
He's a good guy. I've known him for years and years, probably decades. Yeah.
Well, it was like a friend suggestion. All of a sudden, I was like, oh, wait a minute. I was like, that's Ben Zobrist in that picture. Like, holy crap! I have to ask her about that. Like, we're diehard Cubs fans in my house, so.
Yep. He's a really good guy. Really good guy.
Hey, I graduated from Eureka in 1991. Are you married to like Todd or Scott?
Bob, the oldest.
Oh, the oldest. Okay.
Yeah.
All right.
Yeah, I got the best one. Yep.
Oh, okay. Cool.
I had a pleer in my class years ago, a man. Are you married to him?
Yes.
Or is he? Okay.
Yep.
Very good. What was his name?
Steve.
Steve. Tell him I said hi.
I will. He's right here.
Oh, hi, Steve.
Hi.
Small world.
Nice seeing you. Been a while.
Well, you guys, I will see you on Friday.
Thank you.
Take
Bye-bye.
care.
Uh-huh.
Bye.
Bye-bye. Professor, are you still there?
I
By
am.
chance? I do actually have it's a personal question about like cradle cat.
Okay.
So I know we didn't really learn a whole lot about it, but I'm just curious. Like, my daughter is 2. She turned 2 in April, at the end of April, and she still has cradle cat. Is that, it's not necessarily a bad thing, because I guess it's not bothering her or anything. So I just didn't know if that was something I needed to point out to the pediatrician for, if it was like a nutritional issue, or if it's just basically like the brush thing in the bathtub, to get it off.
Yeah. So the best way to get rid of it is baby oil and a comb.
Okay.
Yeah. But no, it shouldn't be indicative of anything really. It's just dandruff. It's just dead skin cells. So you should be good. But I'm sure just pointing it out to your pediatrician would kind of ease your mind a little bit the next time you're there.
Okay, I was just curious. I mean, It's one of those. It's like, you get to the wellness checkups or whatever, and your brain goes blank, and you walk out the door, and you're like, oh,
right.
And that's something that I always forget, and I never remember to ask until just now. So.
In your phone with the next appointment that you put in your calendar, put all your questions right in that calendar appointment, and you'll have them all there ready to go.
Okay, perfect. This is my daughter, by the way. This is Alora.
Beautiful.
Hold on. Can you hear her talking?
You're so pretty. Do you have
say
teeth?
hello?
Show me your teeth.
Oh, she is huge. She has got all her teeth. We're talking about like the developmental milestones and things. I was actually really worried about her speech, because she doesn't really say mine, I, me, do it, nothing like that. But so it's like I'm a true testament to those milestone checks they do, because I was able to pick up on that and point it out to the doctor.
Awesome.
So
good.
Anyway.
Good. But she's not your first child, right?
Yes, she is my first and only. The other one walking around in the background, that's my niece.
Oh, hi, honey. You're pretty too. Aw.
So, nope, I just had that quick question for you. I appreciate it.
Yeah, and I always, even for my own doctor's appointments, I'll put questions right into my calendar.
Right, I need to start doing that too, because I always have tons of questions. I know how to talk, so.
Totally. I appreciate that. You make these sessions a lot better for me.
Well, thank you. I ask a lot of questions, and I can't physically. It hurts me, like the week that I couldn't make it. It hurt me because I was like watching the video and taking notes, and I'm like, I couldn't reply to anything or ask any questions. I'm like, oh no. Sometimes I feel like people get annoyed because all I do is talk, but I'm like, you know what? I'd rather be the one to speak up and ask a dumb question or whatever.
They've all
but-
been good discussions, so thank you.
Right. I really appreciate it. Thank you.
Yep, have a good
I'll
day.
let you go.
Bye, girls.
Bye. Say bye-bye. Bye-bye.